Log on, tune in, find out. Another good idea from Cambridge.
Senior member of the IEEE, associate editor of the IEEE Signal Processing magazine, and his title for us today is on the screen. Thank you very much, Greg.
Thank you. And thank you for this opportunity to come to you and share with you our research on fast conformal mapping for prone supine registration in CT colonography. As Dr. Lee said, I'm Greg Slaybaugh, the head of research and development at MedicSite PLC. And as of January 2012, I'll be at City University London. This work is in collaboration with our partners, Professor Hawkes et al. At University College London and Professor Steve Halligan and his group at University College London Hospital. So first let me introduce you to MedicSite PLC. We're a research-driven SME based in Hammersmith, London, and our core products relate to medical imaging software tools for the detection and diagnosis of disease. We're most active in the lung and the colon, and today my presentation will be on colon. So first let me talk a little bit about colorectal cancer. It's the second most prevalent cancer in Western countries, and worldwide accounts for 1.2 million cases annually, as well as over 600,000 deaths per year. The good news about colorectal cancer, if there is some, is that if it's detected early, 90% of the patients will live at least 10 years. So what I want to impress upon you is that this is a major world healthcare problem. The pathophysiology is quite interesting. Colorectal cancer begins with a hyperproliferation of cells in the lining of the colon, and over time progresses into an adenomatous polyp and then into cancer. When the polyp becomes cancerous, it can then spread metastatically to nearby lymph nodes or other organs such as the liver. The major risk factor for colorectal cancer is age. Individuals 50 years or older are recommended to be screened, and most national programs in various countries have screening programs in place. So the progression here from the hyperproliferation of cells to cancer is quite slow, typically 10 years or more. So the objective here is to detect the polyps while they're still precancerous and then surgically remove them from the patient. The standard approach to screening the colon and preventing the disease is optical colonoscopy. This is an examination of the colon with a flexible video camera. Prior to the exam, for 1 to 3 days, patients are given a low-fiber, clear liquid diet. The patient is also given laxatives to clear the colon. During the procedure, the patient is sedated with an IV line, and the colonoscope is inserted into the rectum and travels through the colon, where the endoscopist looks for any anomalies, such as polyps. During optical colonoscopy, there is an option for surgical treatment using the tools on the colonoscope. So this really is the standard in clinical care for colonoscopy. Any polyps that are found are often removed via a polypectomy procedure, and tissue samples are then sent to the histology for analysis under the microscope to confirm whether the polyp was benign or potentially malignant. While this approach works, it does have some disadvantages. First of all, it's quite invasive, obviously, for the patient. There's a risk of colonic perforation, either from the colonoscope itself or during a polypectomy, and involves the use of sedation, which carries its own risks. And for many of these reasons, there's a large number of patients who don't comply with screening at all and are completely unscreened. The other point to make is that occlusions can make it impossible to see 100% of the colon surface. So at MedicSite, we're very interested in CT colonography. This is an examination of the patient's colon using CT images. The patient is also given laxatives to clear the colon out, and contrast agents as well to opacify any solid or liquid remains. The colon is insufflated with gas, and in fact, at MedicSite, we have an insufflator product that we sell. And 2 images are taken of the patient in supine and prone position while they're in the CT scanner. The radiologist then reviews the data using advanced visualization software to try to detect any of these polyps. So I mentioned CTC. At MedicSite, we're working on CAD, computer-aided detection. So we're applying pattern recognition algorithms to the medical images to identify automatically any potential polyps. These are then relayed to the radiologist reviewing the scan, and they can then examine the CAD marks and determine whether it truly is a polyp or a false positive. In addition, for the radiologist, we're also developing prone supine registration tools. And as I mentioned before, we have 2 scans of the colon. The prone supine registration tries to bring these 2 surfaces of the colon into spatial alignment. And I'll be talking about this in more detail in just a few minutes. So the patients that are positive for polyps can then be referred to colonoscopy. Now, it turns out that approximately 10% of the patients are positive. So that means 90% of the patients can have a CT scan and then just go home. For the remaining 10%, we're working on CTC-OC registration algorithms. Those will take the CT image and align it automatically in real time to the video feed that's coming off of the colonoscope. In addition, we're developing endo-CAD algorithms to detect polyps directly from the video feed during the colonoscopy. And rather than remove all polyps, what we're working on is an optical biopsy algorithm to determine directly from the image alone whether a polyp is adenomatous or hyperplastic. The adenomatous polyps are the ones that need to be removed. So this is the pipeline that we're working on at MedicSite, and we believe this can be transformative for patient care in colorectal health, both for the patient outcome as well as saving hospital costs. So here's just a brief animation showing our CAD at work. On the left, you have a 3D endoluminal fly-through of the colon, and our CAD system produces these red dots. You can kind of see one here. It basically is a point indicating to the radiologist, hey, there's something here, please examine it. Of course, the radiologist has the original CT data that they can review as well in any multiplanar format. So our CAD was recently evaluated in the largest ever study of a colon CAD system. This was done by Perry Pickard at the University of Wisconsin and published in Radiography last year. There were a lot of statistics that came out of that study. The one I want to point out is in this red ellipse. For polyps that were 6 millimeters and greater, these are the polyps that are of clinical interest, our system detected 90%. And this is a really strong result because if you asked expert radiologists to review a set of CT scans, their performance would be approximately 90%. Also in this study, the CAD was shown to identify 15 polyps that were missed by the expert radiologists. So this is further proof that the CAD actually works. Now, when reviewing the data, the radiologist will look at both views, both the prone and the supine, to differentiate polyps from stool. Turns out that polyps remain fixed to the colon surface while stool typically moves as the patient is repositioned in the scanner. The challenge here, though, is for the radiologist, finding the correspondence between the prone and the supine views is very time-consuming and can be quite difficult as well. So what we're trying to do is develop an automatic prone-supine registration algorithm that will bring these 2 surfaces of the colon into spatial alignment. This has the potential to improve radiologist efficiency in reading the data, and we hope it will also improve their accuracy in detecting polyps. Furthermore, this algorithm can be used to improve our CAD system as well. So the objective here is to find a spatial transformation, T of x, that will map a point from the prone surface onto the supine surface. This is actually a really challenging problem because the colon itself is a highly deformable, non-rigid object that changes shape quite severely as the patient is repositioned in the scanner. So our initial approach was just to use out-of-the-box medical imaging techniques. We tried to compute this transformation using non-rigid registration methods applied to the voxel grid. And unfortunately, this resulted in non-physical, unrealistic deformations that were not suitable for our task. So we needed a better way to register these surfaces of the colon. And what we came up with was a technique that takes the 3D surface of the colon and transforms it into the shape of a cylinder using Ricci flow. We can then cut this cylinder open to create an image. So we can do this both for the prone and the supine, and then apply a image registration algorithm to register the two images. Then our full transformation then will be a mapping from the 3D prone surface into the prone image. Then we have a mapping from the prone image to the supine image, then an inverse mapping back to the supine surface. So I mentioned we're using conformal mapping to solve this problem. I'm sure many of you are familiar with conformal mapping. It transforms infinitesimal circles into infinitesimal circles in a way that preserves angles. So if you have a Riemannian metric G, you can apply a conformal deformation G bar, which will preserve the angles. For example, you can see that here we have a 2D texture that has been texture mapped onto the surface of bunny. And if you look at the checkerboard pattern on the surface of the bunny, the orthogonality of the squares is preserved on the surface. So this is a conformal mapping. To solve conformal mapping, we're using Ricci flow, which is an intrinsic geometric flow that deforms the metric of a Riemannian manifold. For a closed surface with Riemannian metric G, the Ricci flow is defined using this equation, where K here is the Gaussian curvature. It conformally scales the metric according to the induced curvature in a way that's kind of analogous to diffusion of heat, and it smooths out the irregularities of the metric. Deforming the metric updates the induced curvature, and you can iterate the PDE until convergence. This equation has a global optimum. The history of Ricci flow is quite interesting. I'm sure many of you are familiar with it. It was introduced in the 80s by Hamilton, and then subsequently refined by several others. Ricci flow was the primary tool used in Perelman's solution of the Poincaré conjecture in 2002. And then Perelman subsequently was awarded a Fields Medal as well as $1 million for his solution, both of which he subsequently declined. It's quite a fascinating story. For us, we're most interested in using Jin et al.'s paper. They provide very practical implementations for triangulated two manifolds. The key to the discrete Ricci flow is circle packing. So what you do is you endow each vertex on the mesh with a radius, gamma, which is a positive value. And each edge is also assigned an angle. So a circle packing metric is composed of these mesh radii as well as the angles. And you can say that two circle packing metrics are equivalent if the angles are equal. So what this allows us to do is change the radii of each vertex, but not change the angles. So we implement the discrete Ricci flow equation. Here there's a term K bar I, and this is a target curvature. So you can specify what curvature you expect at each vertex on the mesh. So for us, we are looking for a 0 Gaussian curvature. So we set Ki equal to 0. And then the implementation is quite straightforward. You compute an initial circle packing metric, and then you can run Ricci flow until convergence, upon which you can then compute the surface layout based on the final metric. So we did that using a gradient descent implementation, and it works quite well. So what I'm showing you here is a zoomed out and zoomed in view of the mesh as we're running the Ricci flow. And what we're showing is the surface layout based on a planar embedding. So initially the mesh looks a bit erratic because it's not actually planar, but as we run the PDE, the mesh becomes more planar, and we get these cracks that start to fill in, and any overlaps are also dealt with. So while this technique works very well, unfortunately it takes about 24 hours to converge for a single mesh. and we have 2 meshes. So this is a real problem for us because, working at a company, we want to make a very practical product that radiologists can use in the clinic. And our clinical partners told us that they were not willing to wait 2 days for a registration. In fact, I've sped this movie up by 10,000 times. So we needed a faster Ricci flow, and for this we ended up with a Newton implementation, which is very appropriate given that we're at the Newton Institute today. This involves the use of a Hessian matrix, and each iteration involves more computation, but the algorithm it converges much more quickly. In fact, it usually converges in about 6 or 7 iterations for our meshes, which have roughly 30,000 triangles. So the good news here is that it converges actually in about 1 minute, which is a great result for us. So once we've run the Ricci flow, then we tile the surface in 2D and extract a cylindrical representation. So going left to right, this is the length along the colon or along the cylinder, and then you have an angular representation that goes around from 0 to 360 degrees. Then what we do is map the shape index from the 3D surface onto this image. And for those of you who aren't familiar with shape index, it's a differential geometric characterization of a surface locally based on principal curvatures. For us, what's most of interest are ridges, because in the colon itself there are lots of house rule folds. The folds have a ridge-like appearance, and in fact you can see them here in this image of the shape index. So they appear as these sort of elongated vertical structures. So we're going to use the folds to drive the registration of the prone and supine images. So this is just an animation showing the transformation of the 3D surface into a cylinder. And as well, we do that for both prone and supine. And then once we've done that, we can then apply a deformable registration algorithm to bring the 2 images into alignment. And this optimizes an energy functional composed of data and regularization terms. The data term will try to get the 2 shape index images to match as closely as possible. Regularization terms try to keep the transformation smooth and non-self-intersecting. So at this point, we've got the full transform now. So we can transform this surface into image. We know the transformation from prone image to supine image, and we can invert the transformation from the supine image back onto the supine surface. Now, something I didn't mention was that the patient's colon may be collapsed in 1 or more views due to poor insufflation. And this is a real challenge because for a lot of patients, there may be a collapse. You can kind of see that here, where the colon appears as 2 disjoint segments. And in practice, there can be more than 2 segments. There could be 3 or 4, depending on the level of insufflation. So these liminal collapses are a bit of a challenge, but we can model them simply by inserting some sort of default values into the shape index image and then handling that specially in the registration algorithm itself. Okay, so for validation, we used 25 cases. These were split up into 12 cases for algorithm development and 13 cases for independent testing. 5 of those 13 cases had a luminal collapse. We asked a radiologist who was experienced with over 500 CTC examinations to provide ground truth labeling of the data sets. This was primarily done by identifying matching coordinates in the supine and prone images. We had 13 polyps as well as 1,175 anatomical reference points that were selected primarily from house rule folds. Our evaluation strategy was to determine the Euclidean distance in 3D from the point that's been transformed into the supine image and the supine point itself. So the results were that all of the polyps were well aligned. The mean polyp registration error was 5.8 millimeters. And the mean error for the anatomical reference points was 6.6 millimeters for well-insufflated cases and 9.7 millimeters for cases with luminal collapse. So these results are quite encouraging. Speaking to our clinical partners, what they would like is for the transformation to be able to transform you from one haustra in the colon to another haustra. So the haustra are the individual sacs of the colon. And typically a haustra is something like 30 millimeters. So we're certainly underneath that requirement. Here's an example of the registration. On the upper left here, we have a 3D rendering of the colon. On the bottom here is one of these shape index images, and on the right is rendering from within the colon itself. So on the prone image, we took this point. It's actually on a polyp. It has a very high shape index. And we transformed that automatically using our registration into the supine image. And it also, this transform point also overlaps with the polyp. So this is a great result because really what we want to do is develop a tool that radiologists can use for visualization so that if they see something of interest, say in the prone image, they can just click on it and instantly have the corresponding view in the supine. Here's another example. Again, good registration. We have a polyp on a fold. You can see it here. And this registration is also quite good. So what I've described up to this point is basically the basic algorithm. What we've done is gone beyond the basic algorithm in a variety of different directions. One thing we've done is tried to improve the initialization of the registration. And for that, we're using a fold matching technique based on Markov random fields. I won't go into all the details. This will be presented at Mackay 2011. But this technique does a much better job for cases with luminal collapse. In fact, we are able to bring the registration error down to 7.7 millimeters. We've also used the registration algorithm to improve our computer-aided detection. The way we do that is we take our CAD marks in, say, the prone image, and we transform them into the supine, and then we go back to an earlier stage in our CAD algorithm and determine if there are any candidate marks there. If there's no match, then we can filter the CAD mark out, assuming that it's false positive. And doing this, we're able to reduce false positives by 25.6% with no impact on sensitivity. This work will be presented at RSNA in a few months. So generally, the registration does a pretty good job, but there are some cases when it fails to produce a good result. And in particular, when the colon exhibits a varying degree of insufflation between prone and supine views. So in fact, you can kind of see it here. In the prone view, this colon doesn't have as much gas in it, and it looks a bit deflated compared to the colon here in the supine view. It turns out for cases like this, the shape index might be slightly different between the prone and supine, so the registration can struggle. We're working on ways to improve the robustness for these varying insufflation cases. Okay, so in summary, I've described a novel prone supine registration algorithm for CT colonography. It uses fast Ricci flow to transform the 3D colon surface into a 2D representation. And then we apply deformable registration in 2D to compute the final alignment. Our results are approximately 6 millimeters in accuracy for well-insufflated cases. Although we're quite interested in the colon in this work, I should point out that the registration approach is generalizable to other anatomies, and that's something that perhaps we'll look at in the future. So that basically concludes my talk. I'd like to thank Dave Hawkes and his team at UCL, in particular Holger Roth, who is doing this work as part of his PhD thesis, and our collaborators at UCLH, Steve Halligan, Darren Boone, and my colleagues at MedicSite, Sujong Yi and Justine McQuillan. Here are a few references. Thank you.
We have a couple of minutes for quick questions. questions if anybody has any wish to.
Instead of rotating the patient, is it possible to change the insufflation degrees?
It is
And to
possible.
create two differences. So,
It is possible to change the insufflation. The insufflators themselves have some controls where you can set the level of insufflation.
Yeah.
So you could do that to generate multiple scans of the colon. But the advantage to turning the patient over is that if there's any stool in the colon, it will move as the patient is repositioned. And based on that degree of motion, a radiologist can then differentiate between polyps and stool. It turns out that stool, in fact, is a very challenging thing to reason about in the CT image.
but when you change the insufflation, I would imagine the relative positions between stool and the polyps will vary as well.
Well,
Does that give you a differential?
it would give you a small differential, but if you can imagine if you've got the colon here and there's a polyp attached to it, or even stool, if you inflate, the polyp and the stool be pretty much in the same position. But if you flip the patient over, the polyp will remain in this location, but the stool will drop down. So based on that degree of motion, the radiologist can then infer that it's actually stool instead of a polyp.
What about dual energy approach?
Great question. There's a lot of interest right now in CT colonography in dual energy, particularly for patients who are maybe a little bit older and can't deal with all of the laxatives that are given, as well as just in clinical practice, things are moving to a laxative-free preparation. So by using dual energy, it becomes a little bit easier to reason about what is stool in the colon and what is not stool. So this is something that's up and coming in the clinical literature. Thank you.
I remember it in one of your critics for other methods is not physical, the deformation. So where is the physics in your method?
Well, we're basing our transformation, we've got the 3D shape of the colon. The shape itself isn't particularly interesting. What we want to do is come up with a technique that is somehow independent of the shape. I mean, the length of the colon is of interest and the things that are along it. But if the colon is moving up or down, that isn't anything of real value in our problem. So by using sort of standard medical imaging techniques, it's difficult to reason about the shape of the colon. What we do is conformally map that onto a plane, and so we take out that degree of freedom essentially in the problem, and so that reduces the complexity of the problem and gives us a solution.
But since it's deformable, then it may not be conformal. The deformable, right? The surface deformable. Then why the mapping has to be conformal?
I suppose it doesn't have to be conformal, but using a conformal technique has some advantages in that it preserves the geometry and the shape of the objects on the colon surface. And that becomes important for us later when we're trying to do the registration.
So you gave us the results for your leaky flow method.
Yes.
Did you also look at the same accuracy or metrics of alignment of your landmarks with the plain non-rigid registration method you referred to earlier? Is that much worse, or?
We didn't do that specifically. Initially we embarked on this sort of standard, voxel-wise registration, but it didn't look promising, so we abandoned that technique altogether.
And the second question, I can have one more, is how good does it have to be? So if you're aiming for regulatory approval as a medical device for diagnosis, what do you have to do in terms of, I don't know, what are you looking for, positive predictive value, negative predictive value, false positive, false negative? What are the metrics that regulators want to see, and what do you have to hit to make it work?
It's a good question. So it depends on the use of the device. If we're using this device for visualization, then our clinical partners have told us that we want to be in the same haustra, so roughly 30 millimeters. Because if you find a polyp in, say, the prone image, click on it, you want to be close to it in the supine image so that the search time is quite reduced for the radiologist. And if you can be right on it, that's even better. But our clinical partners tell us within the same house draw. So that's for visualization. Now for CAD, it's a slightly different story because you want it to be as accurate as possible because if you're going to filter regions out based on the registration, the way we did it was dependent upon a radius. So if you have a misregistration that takes you very far away from a true polyp, then it's potentially possible that you would have false negatives as a result of this filtering. We didn't experience that in our results, but it's possible if there's a bad registration. So I think the key in that application is to know when the registration is good and when to use it. And that's something that we're looking into.
Okay, thanks so much.
When
Very
you
quick.
upload your surface and you have polyps, can you use a couple of polyps as landmarks to co-register? How important is it to be completely automated?
It doesn't have to be completely automated. We could ask the radiologist to identify landmarks, as you suggest, and that can perhaps be an initialization to the registration. The thing is, not all patients have polyps. Polyps can be quite identifiable. Sometimes they're not, but they can be good landmarks. But in the absence of polyps, you're sort of left with haustral folds. And there are a lot of haustral folds in the colon, and it can be a bit confusing even for an expert radiologist to know which haustral fold matches to which haustral fold. So that's why we think an automated approach might be best.
Thank you very much, Greg.
Thank you very much.
Leave it there for the moment. Thank you.